Great presentation. We caught the tail end.
Thank you to everyone who is in attendance. My name is Lane Perkins. I'm with UCB, representing FinTech. We're one of the larger sponsors of the entire event, not this particular session. It's my distinct pleasure to introduce Dr. Kristen Park. She's a pediatric epileptologist. She sees patients in Aurora, Colorado. Her specialties are pediatric neurology and neurophysiology. Dr. Park attended Mayo Medical School and then went on to complete her residency at the Hospital of the University of Pennsylvania and the Children's Hospital of Philadelphia. She has about 15 years of clinical experience, multiple publications, and is currently affiliated with Children's Hospital, Colorado. Dr. Park?
Okay, so my name's Katie. I'm actually not Dr. Park. I am a genetic counselor who is going to be helping her talk about our presentation today, which is genetics and epilepsy. I can't remember if I said this about myself already or not, but I'm a genetic counselor at Children's Hospital, Colorado, in the neurology department. And we are really just going to be doing a more basic introduction to genetics and epilepsy. And that's what I'm going to be starting off with. So first of all, we have no conflicts of interest to disclose. I'm going to begin the overview of genetics, and then Dr. Park is going to kind of do a little bit more specifics of genetics, things that are going on currently, and then we'll do some questions. So back to basics, genetics 101. So our bodies are amazing things. They have so many tasks. And in order to get all of those done, we really need to rely on our genes because we have about 20,000 of them. And they each are designed to have a specific role in the body. So we do have a little video. Can't remember. Is that one already pulled up?
Yeah.
So the video that we're about to show, it's about 2.5 minutes long, and after that, I'll kind of overview it a little bit more, but I think that this is pretty nice because it has visuals. Instead of me just saying some sciencey sounding words, you get to kind of see what it would look like under a very powerful microscope in the body.
Here is a cell, the basic unit of all living tissue. In most human cells, there is a structure called the nucleus. The nucleus contains the genome. In humans, the genome is split between 23 pairs of chromosomes. Each chromosome contains a long strand of DNA, tightly packaged around proteins called histones. Within the DNA are sections called genes. These genes contain the instructions for making proteins. When a gene is switched on, an enzyme called RNA polymerase attaches to the start of the gene. It moves along the DNA, making a strand of messenger RNA out of free bases in the nucleus. The DNA code determines the order in which the free bases are added to the messenger RNA. This process is called transcription. Before the messenger RNA can be used as a template for the production of proteins, it needs to be processed. This involves removing and adding sections of RNA. The messenger RNA then moves out of the nucleus into the cytoplasm. Protein factories in the cytoplasm, called ribosomes, bind to the messenger RNA. The ribosome reads the code in the messenger RNA to produce a chain made up of amino acids. There are 20 different types of amino acid. Transfer RNA molecules carry the amino acids to the ribosome. The messenger RNA is read 3 bases at a time. As each triplet is read, a transfer RNA delivers the corresponding amino acid. This is added added to a growing chain of amino acids. Once the last amino acid has been added, the chain folds into a complex 3D shape to form the protein.
Okay, so I will be honest that I think that that is probably a little bit beyond Genetics 101. Those are topics that you're probably going to be learning about in like AP biology or even, an intro level college biology course. And if you're thinking about how does this apply to my life, you really don't need to know about a lot of those fancy terms like tRNA and mRNA. Really what you need to know is that our DNA, that's like the actual instruction manual for our bodies. A gene is ultimately a long length of DNA, so long length of that information, that instruction, that tells your body how to make a certain protein. Your body knows kind of how to do that machinery to create it with all those other fancy shapes in that video. So kind of taking it back to what do we need to know to apply it to our lives. When it comes to doing genetic testing and the types of results that we can get, sometimes we can find that there are genetic changes that laboratories, researchers, scientists, they've seen them before and they know that they're harmful to the gene. And they can make it so that that protein is not shaped the way it's supposed to. And because of that, it can't go out into the body and accomplish its task like it was originally supposed to. We also know that sometimes we can get negative results in genetics where the test that we ordered, it didn't find a result, but that doesn't mean that someone doesn't have a genetic condition or an underlying reason for their epilepsy. And we can kind of talk a little bit more throughout this presentation on why we can have a negative test result and still perhaps have an underlying genetic cause. And we can also get a result that's a little bit in between those. We call it a variant of uncertain significance. And this means that the laboratory just hasn't seen that genetic change enough to know whether it might be harmful to the body and result in a genetic condition, or whether it might just be kind of part of normal human variation, part of what makes our diversity so beautiful. And is not harmful to the body. At the bottom of this slide, we can see typos and quotation marks. That's kind of what we think about with these genetic changes sometimes that are harmful. It's like those little spellings, those base pairs, letters ultimately. If those get changed, even if it's just one letter, that can be very impactful on the body in some cases. There is this white table on the right, and I know that they kind of just look like colored dots here, but ultimately what it's showing is that the way that that gene is spelled can determine what amino acid is put into that protein. And those amino acids, they're kind of like beads on a string that ultimately create that protein. And they have their own chemistry that once that all of those beads are added to that string, it makes it so that it kind of folds onto each other in certain ways. And it works, and based on the way that it's kind of folded together, that's how it goes into the body and is able to accomplish whatever task it's designed to do. So we know that, sometimes we can spell these different amino acids in different ways, and it still creates the same amino acid. So sometimes we know that you can have a spelling difference, and it's not going to be harmful. But if you change that spelling in, just the wrong way, it can ultimately change what bead is added to that string and how that protein ultimately kind of folds together. Now, these spelling changes aren't the only type of genetic change that our bodies can have, but this is one of the most common ones that we think about. We can also see deletions, so areas that are gone, duplications, so areas that are added, as well as some other interesting but more rare changes. So these are things that were kind of shown in this video as well. We all have 23 pairs of chromosomes. Chromosomes are those X-looking structures that ultimately just hold that DNA really tightly together, wound up. It's kind of how it just fits it all into your cells so nicely. So 23 pairs, we all inherit one chromosome from one parent and the other chromosome from the other parent. And so that's why we often talk about how typically we'll have 2 copies of each gene. That's not the case for that 23rd pair of chromosomes because that can be different amongst different people. Males tend to have an X chromosome and a Y chromosome. Females tend to have an X and an X. And so that can be for genetic conditions that are caused by genes within those chromosomes, that inheritance can look a little bit different. And so I'll talk about that a little bit as well. Allele on here. So there are many words that you might see when looking at a genetic test or different reports online. Variant is what you'll see most commonly for the name of a genetic change. Sometimes you'll see the word mutation. That's really going to be the same thing, but it's kind of it's less, I guess in my mind, scientific. When we say variant, we can say, yes, we think this is a pathogenic variant, meaning we think that this genetic change is harmful. We can also say, it's a benign variant, meaning that it is a genetic change, but it doesn't hurt anything. Mutation, mostly that would mean, yes, this is a harmful genetic change. Allele, also like a variant. Hello? I think you guys can't hear me anymore, can you? I think the mic went out. Oh, okay, great. So,
you're pretty good at projecting that.
Okay, you guys can hear me all right, even if it's kind of going in and out a little bit?
Try that one that's up to the...
Oh, good idea.
Okay, never mind.
So the last thing that I will talk about before I kind of turn it over to Dr. Park, who is fortunately very good at projecting as well, is that, talking about inheritance patterns and how I said we typically have 2 copies of each gene. We know that for some genetic conditions, it has an autosomal dominant inheritance pattern. Basically means that out of those 2 genes, you need to have one of them with a harmful genetic change in it in order to be affected by that genetic condition. If you have your other one that does work, it's not enough to be not affected. Kind of on the flip side, if you have autosomal recessive genetic conditions, if both of those copies don't work, that's when you would have the genetic condition. X-linked, as I was saying with those X and Y chromosomes, that can be a little bit different. When we think about X-linked inheritance, we'll often see those with XY chromosomes, or typically males, will be affected by the genetic condition, but the females actually usually will not. And that's because those males, they'll have a harmful genetic change on that X chromosome, and they don't have another working copy of that gene in order to give them enough working protein to not be affected. Whereas females, since they have one copy of that X that does work and one copy of the X that doesn't, they're all right because they have that one working X to kind of give them what they need. Ultimately, inheritance patterns can really change depending on the gene, the change specifically, and that's why having these conversations with your healthcare providers who order the testing or the genetic counselors that they might have on staff can be really helpful, because it truly can be case-by-case basis, and genetics can be pretty wild. So we often like to have pretty tailored discussions, just kind of based on what we're looking at. And with that, I will hand it over to Dr. Park for the moment.
All right, great, thanks. All right, so, we've been talking about genetics, and so now we're going to talk about different types of epilepsy and bring it to where we're all interested in hearing it go. Epilepsy previously has been divided into it's either genetic or it's acquired. There's been some other incident, someone had a stroke, someone had meningitis, someone had a head injury, and therefore the epilepsy is acquired. But I think it's not actually that simple, and there are more gradations to that. So genetic epilepsy can follow a couple of different patterns. One pattern is called Mendelian, and that comes from Gregor Mendel, who was the monk that bred all the different peas together and watched their flowers and their leaves change. And essentially that boils down to one gene causing a particular condition. And then the other half of that being polygenic, meaning that it's a number of different genes that add together to result in the condition. So there's a little bit of variation there. And then there's also subtle genetic influences that go into acquired epilepsies. So they've done some research of people with strokes, and of the, say, if we took 100 people who had a neonatal stroke, a stroke when they were a baby, probably only 30% of them, or 30 of them, would develop epilepsy. And if we looked at those 30 people, more of their family members may have had a provoked seizure at some point in their life. More of their family members may have had a febrile seizure or an alcohol withdrawal seizure, or actually have epilepsy. And so there's even some genetic influence at play there, even though it's not as easy to decipher. We've also known that for a long, long time that epilepsy is genetic. So we've known since Hippocrates that it tends to run in families. It tends to be additive. So if more than one family member has epilepsy, the risk increases. It can be related to what type of epilepsy someone has. So absence seizures seem to be a bit more heritable than other types of epilepsy. The risks are probably not to the point where it's all one gene. The risks are only slightly increased from the general population risk, which is about 1%. If you have a person with epilepsy, that they have a child with epilepsy is probably going to be ranging from 2 to 8%. So not probably related to one gene, but probably, again, related to multiple factors. So what do we know about epilepsy genetics at this point? So currently there are about 800 genes that are associated mostly with epilepsy as the main symptom. If we look at other disorders that result in, say, autism or intellectual disability or cerebral palsy or other motor problems, hypotonia, that list balloons up to about several thousand. And you can see that this timeline here starts with the first discovery of the epilepsy gene for frontal lobe epilepsy back in 1995. And it kind of, went along, and then it's just exploded recently, such that we, went from being able to test for one gene when I started practicing to now being able to test for thousands of them. So most of the time when we find a single gene related to a significant epilepsy, that's often what we call de novo, meaning that even though it's genetic, it wasn't necessarily inherited. So each of us, when we start out as an egg and a sperm, we have to take that single cell that we start at and copy all that genetic material over and over and over and over and over again. And if you imagine that you as a person were trying to copy the encyclopedia over and over again, millions of times, you might put one letter where there should have been a different letter. And so that's what happens, is that as the child is being made and formed, one of those letters gets switched. And so that is called de novo, that it wasn't inherited from a parent, it arose newly in the child. But I think, just because we know that doesn't mean we have the answers to all of the things that we know about epilepsy. A lot of times parents can be mosaic, so meaning that some of the cells in their body have the genetic change that their child has, and some of them don't. And so they may not have any symptoms or know that they had passed this down because they never had a seizure. So it's very important a lot of times to test families, even if there isn't a family history of epilepsy. When we do suspect that epilepsy is genetic and we do testing, unfortunately we don't always get an answer. Depends, number one, on the tests that we do, as Katie said, but also on the fact that we don't even know what all of the genes in our bodies do. So Katie mentioned we have about 20,000 genes in our body. We probably at the moment know what about 8,000 of them do. So that means we're missing 12,000 genes and understanding what it is that what role they play in how our body functions. When we think about epilepsy genes, they can affect a number of different things, right? Why do they cause epilepsy? What do they do? What are those proteins supposed to do in our body? And certainly they are in our brain. A lot of them have to do with ion channels, so the flow of charged particles in and out of our neurons, the cells in our brain. And those charged particles allow our brain cells to communicate electrically. So our brain cells communicate electrically and chemically. And electrically they use these ions. They use sodium and potassium and chloride, and that flow in and out of the cell is what allows those electrical potentials to travel between neurons. Our neurons also build connections between each other called synapses, and a lot of proteins are involved in making those connections so that when one cell fires, another cell fires and sends the message on down the chain. Those synapses are formed by proteins as well, which can be involved in epilepsy genetics. There are also, we saw on the video that those genes are packaged tightly around things called chromatin. So there are a number of mutations in chromatin that are known to result in some of those more complex syndromes like Rett syndrome, CHD2 or ARX. All of those are related to how our chromatin is functioning. It also opens to allow those genes to be transcribed and then kind of binds itself back up to put the genes back and hide them from being used. And then finally, another pathway there is the mTOR pathway that kind of regulates growth and development in our body and is involved in a lot of some of the more common and well-known epilepsies like tuberous sclerosis is in that pathway. So let's talk a little bit about one of the most common epilepsy genes. One of the first ones that was discovered was SCN1A, so that stands for sodium channel 1A, S for sodium, CN for channel 1A, and that's kind of its like number in the family of sodium channels. We have 10, 12 sodium channels in our body. This is member 1A. And that initially was described clinically by somebody in the 70s who noticed, wow, these patients look a little bit different than the other patients that they've been lumped with. I think they might have the same thing. And her name was Charlotte Dravet. And then in 1997, some group in Australia kind of took a huge family where a number of different people had epilepsy, and they all often had epilepsy or seizures related to fever. And they said, let's see if this family is somehow related to this presentation. And they kind of linked all the people together in that family who had epilepsy and were able to find a particular spot and show that it was this sodium channel. And so they kind of put the two and two together and were able to figure out that Dravet syndrome overlapped with that sodium channel, and then it became kind of one of the first epilepsy genes. And now it's kind of exploded into this huge foundation. They're doing epilepsy genetic research. They're getting ready to do clinical trials about specific treatments that may help to modify those genetic changes. They have databases to help people interpret genetic test results. There have been enough patients together that we know that certain medicines are better than other medicines for treating those children. They have animal models, and they are now developing gene therapy. And so I think this is the power of getting a genetic and precise diagnosis, is that it can then drive this research to be able to treat the epilepsy better than the current treatments that we use, which are very nonspecific. So I think other implications are that they may want to know about recurrence risk, right? If someone has epilepsy, what is the chance that somebody else in the family is going to have epilepsy, either their own child or their sister or their cousin who's getting ready to have kids? That's very important. Sometimes it can help us tell what's going to happen in the future. Is this epilepsy going to be something that child outgrows? Is it going to be something that gets worse in the future? Is it something that surgery is going to be able to help? What do we know if we have this precise diagnosis? And when we've done studies, we know that if we give someone a genetic diagnosis, about half the time it will change what their doctor does for them. It will change the medicine that they take. It will change the course of how their epilepsy is managed. Unfortunately, it often takes a long time for people to get a genetic diagnosis, on average years. And so I think this is kind of something that I'd like to see change in the future as we have more access to genetic testing, that it takes less time for people to be able to speak with their doctors and get answers for their family member. Oops. Okay, so I think a couple of other epilepsies that kind of fall into this same category, where we've learned a lot and we've changed and done things differently. This was benign familial neonatal convulsions, or BFNC, also BFNS. Again, kind of similar thing. It was described very early on, and only through years and years of research were we able to identify that it was related to a potassium channel and a particular way that neuron communicates electrically. And so from that information, people were able to develop a new therapy for epilepsy. Initially, it was used for all people with epilepsy, not just people with this particular kind of epilepsy. And it had been approved by the FDA, but it was withdrawn from the market, although I do know that it's kind of currently in clinical trials again to be able to be used. And so understanding the genetic underpinnings of epilepsy not only helps us to treat the individual patient, it also helps us to further epilepsy research in general, develop new therapies based on our understanding of how epilepsy presents and all of the mechanisms and pathophysiology that's involved in that. So I want to bring this case up because I used to have some kind of requirements that people had to meet before I would send genetic testing. And I'm a big proponent of genetic testing myself. I test almost everyone, but it usually was someone who had treatment-resistant epilepsy or also had other features or, seemed to be not quite matching what I thought their course should be. And this case to me highlighted I should probably just test everyone and everyone should get genetic testing. And that was because this young man had his first seizure at 5 years of age. He had normal development. A normal birth history. He had no risk factors. There were people in his family who had seizures, his mom and his older sister, and he was diagnosed with what's now called SELEX, self-limited epilepsy with centrotemporal spikes, previously known as KEX here, or BRE or BREX. We like to name things a lot and change their names over time, but anyway, he had this kind of very benign childhood epilepsy. But unfortunately, he wasn't responding to the typical medicines that we chose for him, and it kind of kept having seizures, and he was being worked up for surgery. And he underwent genetic testing as on average 5 years after he presented, and he was actually found to have an SCN1A variant, which is completely unexpected because that's not usually how that type of epilepsy presents. It was also seen in his family member, and initially they kind of said, well, we're not really sure about that because it doesn't seem to fit, but then we tested other family members and said, nope, it really tracks. Everybody who has epilepsy has this particular genetic variant. And he had been, again, having intractable seizures. Well, we had him on a medicine that was inappropriate for someone with that genetic variant. And so we changed his medicines to those that were more appropriate for people with SCN1A, and he's been seizure-free. And so to me, that is like, I would never have tested that kid 5 years ago. And now I think, again, I should just test everyone. So I think the what I will say is that most of those thousands of genes and hundreds of genes that I talked about have been epilepsy that has severe onset in childhood. And I don't really know how many people there are out there like that child that I followed. How common is that? And, how often should we be finding people like that and helping to change the course of their treatment? I think, again, we're still at this low diagnostic rate, but hopefully as people get more and more testing, we understand more and more, we learn more and more about those genes, we'll get more answers for people. So that's kind of monogenetic epilepsies. I'm going to turn back over to Katie to talk about polygenetic or Mendelian, non-Mendelian epilepsy genetics, which is a little bit more complicated, but we'll try and keep it short so that we can get to some questions.
Okay. So this is going to be going back to what I was asking earlier about why can we have negative genetic test results when we really suspect that someone has an underlying genetic cause still? And one of the theories is that it's due to polygenic epilepsies, which really means that instead of it being mono, where there's only one genetic change, or one gene that has a harmful genetic change, really we think that there are multiple genes involved that all have some genetic change that increases their risk of developing seizures slightly. And so if you think about if you have multiple genes that add a little bit more risk for developing a seizure, someone might end up going past a threshold where they would then develop those seizures and you would see it in front of you. Oh, thank you. Okay. Does that change anything? No. That's okay.
Oh, the battery died.
Yeah. Okay. That's fine.
It's just done. Okay.
Trying to remember what I say. Polygenic. Okay, yes. But so if you have multiple of those genes that all increase your risk very slightly, if you do genetic testing, you're probably not going to find out about all of those. And so that's why on here you'll see complex inheritance, because really it is complex. It's going to be more complicated than just I inherited this one genetic change from one of my parents and this is why my genetic epilepsy has occurred. And so this is pretty difficult to figure out, and it's really because it's hard to study this. We need to have, studies that have thousands of people in them in order to even start to see some of these associations, or where, if we see genetic changes in these two genes going on, but fortunately, there is research going on to go in that direction and help us to learn about this more. So recently, there was a study with 3,000 people with epilepsy, and they found 29 correlations between different genes, and that's to GGE, which is generalized genetic epilepsy. And so, yes. I think that I'm going to leave it there and then come down so that we can answer some questions and hopefully. Okay, yeah, maybe we'll do that here then. Oh, actually there was one more slide. Rounding it off, kind of precision medicine, and this really is the idea of tailoring somebody's healthcare based off of a genetic result. And this can be helpful in circumstances where, maybe we know of this genetic change, this genetic condition, perhaps things like Dr. Park was saying, we know that there's an anti-seizure medication that can work better for that, or actually work worse and we should avoid it. And it's even going into the direction of developing things like gene therapies to perhaps help boost what that gene was supposed to do, or really just give those instructions to the body on how to make that protein correctly in the first place. So now I will switch it to us taking questions.
Yeah.
Okay.
And that's our disclaimer. Awesome.
My daughter had genetic testing 3 years ago, almost 3 years ago, and she's, she's an adult. So I wanted to put in a plug too for genetic testing for adults. A lot of people say, well, not a child, it's not going to help, but it has helped because we found some answers, and she's got she inherited from me. I have something called SED.
Uh-huh. Yep.
And I don't have epilepsy.
Yep.
But she does.
Yep.
And it's not one of the common ones that can cause it. And so her genetic physician was able to identify, they said Depakote would be the drug of choice right now for her. And we have gone through a lot of different drugs that were making things worse, and found out really her sodium channel blockers
Yep.
get worse. So it's really,
Yep.
even if you're an adult, you
Yep.
shouldn't think, oh, it's not going to help.
Right. So the question was talking about the difference between genetic testing in children versus adults. And there actually has been some literature that suggests that if we look at the number of positive, meaning diagnostic test results in pediatrics, and we translate that and test people as adults, we get the same number. And the same thing happens, right? 40% of the time in children it changes management, 40% of times in adults it changes management. The issue is just that the adult neurologists, I think, are a lot further behind in testing people because they just don't think about it as often. Most of the people that they treat have had some other issue. They mostly have acquired epilepsies, whereas pediatrics kind of lives in the congenital and from birth world where most things we think of, and we think of genetics more often. So I think they really just need to catch up, and we're trying to help them to do that, to be able to test more frequently, to be able to interpret the results that they get. But you're absolutely right. It really is something that can have a life-changing impact at any age to find those answers, because what we really want is for it to be translated into a better treatment for the person with seizures.
They don't want to pay for the adults.
Also true. That the big thing in the United States is that genetic testing is not equally available to all, and there is a big discrepancy for adults, and that's why we have some of that research to try and bring it back to the insurance company to say, well, you may think that it's irrelevant, but here is the research that says that it actually has the same benefit for adults that it has for children.
Yeah, and another thing to think about is maybe somebody who is an adult now and they don't have a genetic answer to their epilepsy. Maybe they had genetic testing done first years ago. And, as we've talked about with the evolution of genetic testing with epilepsy, what was it, like 15 years ago, there wasn't much genetic testing that you could do. And so someone, now an adult thinking about, hey, maybe it would make sense for me to have genetic testing done again, but with, encompassing what we know now, more comprehensive genetic testing. That's absolutely something that can be brought up. And it can be helpful for, things besides just medical care as well, things like family planning, just having a bit more understanding of why is this going on, what would my chances be to have a child with this same epilepsy condition as well. And so it can be useful beyond just, tailoring care.
You mentioned that it was inherited and that you didn't have seizures, and I think that's something else that happens frequently is many of our genes, they have different penetrance, meaning that sometimes there are a number of factors that need to go into whether that gene is expressed in someone. They may be environmental factors or other genetic factors, so that they carry a variant in that gene, but nothing ever happened because of it, because some other things were at play, and that happens quite frequently. So penetrance of genes can range from 20 to 100%. And so we don't really know about that unless we do testing. And we should also keep in mind that as people, as reproductive people, we don't choose the genes that we pass on to our children, right? They get what they get when the egg and sperm combine, and that wasn't anybody's, fault or choice. It's just kind of how nature worked out.
Right.
Do you, once you identify, you have, the gene deficiency, or once you identify that, how often do you suggest people go back to the genetic doctor to get tested again?
Yeah, well, I don't know that we suggest that they go back to get tested again, but I think often we recommend follow-up in 1 to 2 years to kind of keep abreast of the knowledge of that gene to see if anything has changed. Say, oh, look, we've now seen 50 more people with that genetic variation, and we know that it can cause heart problems as you get older. So maybe you should have your heart screened. Or hey, there's this new trial that's happening that we want to tell you about that's doing research, and we would like to send you there for more information. So I think every couple of years there's kind of a refresh of information that can be useful and helpful. I think the fact that could there be other contributors, as we talked about with polygenic things, I think that's going to take a longer time to sort out, to do additional testing. But I'd say at least for follow-up, every couple of years is recommended.
Another reason why doing follow-up can be helpful is you might have a positive result, or you might have, gotten an answer to the underlying cause, but maybe you also had some other variants that were identified on that genetic test, those variants of uncertain significance. And we know that these laboratories, they're always working to gather more information. As she was saying, they see other people who had testing done with that same place who had this genetic change, and basically they're able to reclassify those changes, meaning they're able to change it from uncertain to, yes, we do think that this is, harmful and can lead to a genetic condition, or to, we think this is negative, not harmful. So it can be nice to kind of follow up and just say, has it been reclassified yet? Can we kind of seal the book on that genetic change? Sometimes that can take years, though. It really can depend on really what that genetic change is. But any healthcare provider really can look to see if those variants have been reclassified. There are online databases where, we can check and see laboratories. They say, yes, we've seen this genetic change before, and we think that it is harmful. It doesn't give you any personal information about people who had that result. It just says, yes, we think that this change is XYZ harmful or not. And so those doctors, they can look and see, how has it been classified by other labs? Or they can even just contact that laboratory who did the testing initially and just say, hey, have you guys reclassified it? So that's certainly something to kind of have on your radar. I know that variants of uncertain significance are just quite common, so this is probably something that a lot of people are familiar with.
Our microphone. Other questions? Yeah.
I've noticed not all level 4 epilepsy centers have genetics or genetic clinics. Do you think in the future that epilepsy centers that don't have that are going to be classified down to level 3s?
I would think so, and I would hope so, because I think it's going to have a bigger and bigger impact on the driving of epilepsy care for doing clinical trials and research and medications to affecting surgical decisions and how they are made. So I think it should be, but I don't have any control over that. But I think it should be part of every comprehensive epilepsy center.
Mm-hmm.
Okay.
Okay. All right.
Awesome. Well, thanks so much. We'll be around at
Yeah.
our children's table if anybody wants to stop by and ask questions in person. And thanks for listening.
Yeah.